talking about KAMRA. We're so glad that you could join us. I could see you guys popping in on the screen here. I just want to let you know that we do have a chat box at the bottom, so feel free to answer, go ahead and ask your questions, and then Dr. Foulkes will try to get to all of them at the end. So I just wanted to let anybody know that's joining us. So go ahead, Dr. Foulkes, take over.
Hey, hi guys. Listen, thanks so much for joining me here for this webinar, and I hope that in the next few minutes you can get at least an introduction into this amazing, really cool idea called KAMRA. I had kind of a long history here with this tool. I helped develop a laser that's used for doing LASIK flaps and many procedures inside the cornea that's called the seam or femtosecond laser. And through my work with that, I helped this company essentially make a pocket that would allow us to insert this little device into a cornea. And so I'll get into that as we go along. But this is really how I initially got involved with this product. I am Richard Foulkes has me there with Florence, who also has a presbyopic correction, and I have a interesting history, a Vietnam veteran. Was a corpsman working as a surgical technician there, and it just sort of became my life thing to become a surgeon. So I eventually went to Tufts undergraduate and then Rush Medical College. I trained out in New York at Cornell, New York Hospital. And my training boss there, Dr. David Payton, introduced me to a fellow named Lucio Brado that started the whole LASIK world in motion. And I eventually became a LASIK surgeon in the late 90s and have been at that ever since. And this tool just fits into that technology like hand in glove, and I'll explain that to you as we go along.
Hey, Dr. Foulkes, your audio is a little breaking up a little bit. I'm not sure what happened there, but
okay, all right. I'll tell you what.
It might be.
I'm going to get off this. I'm going to get off my my Bluetooth here.
Okay.
One second, and I'll just improve things. Hopefully I don't lose you here now.
Oh, that sounds better. Is that better?
Oh, yeah.
Much clearer, yeah.
Took a second there, but so I got you on the thing. So all right, well, let's just go through this slide set then. All right, so this is, we're going down this pathway of understanding blur. So, there's various ways that we see blur that we don't see clearly. So just to, not to bore you with this, but essentially we're either nearsighted, which means your eyeball typically is a little too long, or in some cases the cornea, the front focusing element of your eye, is a little too steep, which makes it a stronger magnifier. But in any case, nearsighted people are over-magnified. So they have great vision up close, but it's a little blurry far away. So distance objects will appear blurry for these folks, right? So this is nearsighted. Now, that's something I am, is nearsighted. And farsightedness is kind of the opposite. These folks typically have a slightly smaller eyeball, so that the images are not focusing on the retina. They actually focus in behind the retina. So then in their youth, they're able to use the muscle in their eye to flex the lens, which sits behind the pupil, to make it a stronger magnifier. And in doing so, you can then pull in near objects, and you can gain magnification to allow you to see far and then all the way to near. And same thing is happening in nearsighted people. It's just that they need to use that magnifier less to be able to see close. So astigmatism, astigmatism is a little hard to understand, but suffice it to say that in astigmatism, your cornea is flat in one direction and steep in the opposite direction, which usually we say this is like a football. So a football shape has a flat long length and then a steeper round length that comes around to allow you to grab the ball. And in human eyes, the problem for this is that part of your vision will typically be a little bit more nearsighted or farsighted than the opposite vision. And so this creates a kind of a blur, but it also, in a way, can be seen as dragging some of the available light rays, out of your vision. So people that have astigmatism often can see relatively well. It's just that it's not sharp. They don't really have a sharp vision because part of the light rays are being put in and out of focus unless it's corrected. So presbyopia is really what you guys are here for, I think, most of you. The presbyopia is the state that we hit typically when the muscle power in our eye cannot cause the lens to continue to reshape itself into a magnifier. And this typically happens in our 40s. Often it's pretty much complete by the time we're in our 50s. What's really happening when that's occurring, sad to say, is you're developing a little bit of a cataract. And cataract is essentially an aging of the lens in your eye. And as the lens ages, it gets stiff. And the stiffer it gets, the more you can't quite draw in the near vision. If you're nearsighted, when you have your nearsighted glasses on, then you can't draw in the near. And so what do we do for that? Well, we give you a magnifier. We give you a magnification that the lens is no longer able to give you. So this is the need for magnifiers, either as a bifocal, which can be built into glasses, or as a separate pair of glasses. So the treatment for presbyopia, again, as I was saying here, this is like an early cataract presbyopia. The next stage up the road for people is cataract itself. And this cataract is just an opacification or buildup of waste product inside the lens of your eye. And it will slowly build up. We often, historically, would wait for you to be nearly stone blind from a cataract before we do the cataract surgery. But modern techniques have allowed us to approach cataract surgery more as a visual disability that we can approach younger in life. And we're often doing cataracts now closer to 60 or even younger in some people. And certainly the advantage of cataract surgery for most people by that time is that we can restore back all the portions of your vision. We can get you back both near, far, and also brighter and more colorized vision. Cataracts often turn a bit yellow, and so this reduces the color scale for you. So lots of reading, obviously, for all these things. It's a hassle. And when you can't see up close, as you well know, it sucks. In fact, one would say, in many ways, part of the reason that I've left myself a little nearsighted, even though I had LASIK, is because I recognize so much of what I do is actually within my arm's length. I don't drive a truck as often as that would, make that my number one focus. And so for me, having near vision is just a critical thing. Computers, cooking, conversations, everything we do is within that arm's length. And when we get into this presbyopic state, obviously all these things become more difficult. So reading glasses, obviously the standard thing that we do for this. You can also, talk about monovision with contact lenses. Some people do this. They'll wear a contact lens that allows them to get one eye to see up close. There are also multifocal contact lenses that give you kind of a double image, both near and far. And these are all options for people. The problem with monovision is you're kind of breaking the way the eye is, or the brain and the eye work together. So when you try to see the world one eye at a time, there's several functions in your brain that are no longer functioning as well, and this will degrade your ability to see far. And it also interferes with some of the quick functioning talents that we have, like depth perception, to be able to grab something in space. So sports activities, these kind of things are degraded significantly when you separate the two eyes and the two eyes can't fuse together. So what about the KAMRA Inlay? That's what you're here for. Well, the KAMRA Inlay came around probably a decade ago. The patent was written just a few years before that. And what we had in mind was to take a trick that we've known in optics for a very long time and apply this as an apparatus that you could actually wear inside your eye. And so how does KAMRA work? Well, the way KAMRA is, the optical principle we're working on is the same principle that we talk about, and that's where the name comes from, when you have a 35 millimeter camera. So when you have a camera and you want to get a picture with a bee, a flower, and the tree in the background, you reduce the so-called f-stop. That's the f-stop, or you enlarge the f-stop in the camera. And the f-stop will make the aperture inside the camera get smaller and smaller and smaller. And until you can get all three of those objects in focus with a fairly small, let's say 1.3 to 1.5 millimeter aperture. And as you make it slightly bigger, well, the tree starts to fade out of focus, but the bee and the flower will remain in focus. And bigger still, now you've got your bee in focus and the flower still in soft focus behind it. So the pinhole effect limits the light rays of the ones coming right through the center of any optic. And it gives you depth of focus. Depth of focus is, in fact, what the camera inlay is all about. And if you have an interest in this thing, this hopefully will be your takeaway message today, that this is a unique, incredibly unique, and very exciting new thing that we've been able to apply to allow you to give a kind of a vision that you really can't get by any other means. This is the only way that I know that you can actually achieve this particular type of vision. So the camera inlay is a tiny little ring. I'm going to show you pictures of it. This little ring has about a 1.3 millimeter internal aperture. It's about 3.4 millimeters, 3.6 millimeters in total width. It has 8,500, 8,400 tiny little laser cut holes in that black section you're seeing and that tiny object there. Those are there to allow oxygen and nutrients to pass through the device so that the cornea will remain happy above it. The cornea gets its nutrients from the internal fluid that's inside your eye and from oxygen that's on the surface. So we don't want to interfere with that process, and the camera's been designed to do that. It's also very, very thin. It's about 5 microns thick. So it doesn't cause any curvature change in your cornea. It's leaving the curvature exactly as it was. So here's some 7 key points I want to make about the camera. This is a photograph taken at one of our little lamps that we use for doing close-up images of your eye. And you can see this little 3-point-something, 8 millimeter object that's sitting in that patient's cornea. Now, when I stand back from this patient, all I'll typically see is a pupil. It looks like a pupil. You won't see this sitting in the eye. So it's not that easy to see. Even in a blue eye, it will look really pretty much like your pupil. The pinhole aperture, though, gives you this depth of focus. And again, that's the key to this thing. With the depth of focus, the light rays are all in focus. So the light rays that dominate will be those that are passing through at arm's length. So what we therefore try to do is leave you just slightly nearsighted to improve your near power. So the ideal power to have for the camera inlay is just a little bit nearsighted. So imagine that I'm letting the light rays pass in through this small aperture in the center part of your eye. But if I have limited to the light rays, the ones that are a little bit closer to you, those within arm's length, what will happen is the slight blur you'd have at distance will be cleared up. Meanwhile, the near power will be at least double, so you'll have at least a plus 150 magnifier essentially on your face. And if any of you currently wear magnifiers, you know that these numbers about 150 are what one needs to see within arm's length. So this can be done, all this work can be done the day of surgery. So if you are currently a little bit farsighted or if you're a little bit too nearsighted, what we can do is we can essentially use the excimer laser, the corneal shaping laser, to give you this exact prescription power that we know works the best with this particular device, and then insert the camera inlay. So this can also be done later. So if we place the object in your eye, the camera in your eye, and we find later that you're needing a little bit more near power, this can be done. So we can have that additional power later if we need to on top of the camera. Since you're looking through this pinhole, you do still need relatively good light. So one limitation of the camera, minor limitation, no one seems to complain of it, is that it's still, because of this small aperture, like you can imagine a small pupil, we like you to have good light. So the better light you have, the more finer print you can see. So the actual inlays here are kept in perfect position. We'd like it to be exactly over the center of your vision. And we achieved this with a really incredible technology that came with the camera, which we call AccuTarget HD. So when you come in for your evaluation, we're going to put you on this amazing tool that will tell us a bunch of really important things to let us know that you'll be a good candidate for this. So as an example, when you're limiting the vision to just that small little aperture you're seeing in the right-hand image, you need your cornea up there to be nicely lubricated. That cornea has to be happy and dry. It has to be, in just an ideal sort of set, so that your vision coming through that small aperture will be as sharp as you possibly can be. So with this AccuFocus Target device, we're able to actually ascertain the visual quality that we see through the center part of your cornea. So, for instance, when you come in for your evaluation, if we find your eye's been a little dry, perhaps the optical quality not as sharp as we think it can be, then we're going to help you with that. We're going to give you some drops to use. We might put you on, have you use little fish oils, or we've got some lid issues we can often address to improve your dry eye if you have that. So that when you finally have this device placed, we see, you get the most optimal view through that small aperture. And again, as we move forward in time, you'll see this same effect in place. So when we do these procedures, there's a series of steps you're going to go through. So again, this slide is sort of in here to sort of show you that as we age, these natural processes occur with presbyopia, where whatever your vision was, near or farsighted, you no longer can change your focus because remember, as I told you, the lens has become stiff and it can't globulize or become thick to give you more magnification. So what's neat is this KAMRA Inlay essentially flatlines that degradation in your vision, so the vision will not degrade over time, right on through until presumably you reach the years when you've got a cataract. And now what we've found is that if we remove your cataract with this camera in your eye, that on the other side of having the cataract removed, now you have a small little implant inside your eye, which is a tiny lens that replaces the lens that has become cloudy in your eye. And you know what? The camera works wonderfully through this. In fact, maybe even better, because you don't have that opacification in your eye anymore. The cataract's been removed. And so we've seen really great results in patients that have had our post-cataract. So we really think of KAMRA as a lifetime solution. This ought to be something, once you're onto this trick and really have it working for yourself, that you can use literally for the rest of your life to maintain your near and far vision. So pretty cool. The KAMRA Inlay procedure basically takes me approximately 10 to 15 minutes. The procedure involves placing a small pocket using a femtosecond laser, this very cool laser I initiated this conversation about today, that I am the medical monitor for. I'm actually helped develop this device. And it's a really amazing laser that allows us to place these incredibly fine little passages anywhere we'd like in the cornea. And in this case, we're just going to make a little central passage over through to the center part of your vision. And then what I do is I place the little KAMRA Inlay into a forceps and perfectly centered over the center of your vision. And I've gone to some effort to advance the technique here for perfect placement. That AccuFocus HD device I showed you earlier is very helpful this way. This will confirm that we've got it perfectly centered. But what I did was I bought a microscope and I got a really cool focusing beam that you'll be able to stare up at. And while you're doing that, I'm seeing the reflectance of this little red beam coming right through the center of your camera, so I can place it exactly through the center of the inlay. And this, I believe, is incredibly important. Really improves the effect of this device. We can get it within these, under 100 microns of perfect centration. It's interesting because we don't really look through the very center of our pupil. That little flashing white spot you see in this lady's eye is what we call her Purkinje. So the Purkinje is the reflected light off the cornea, and it's telling us exactly where the vision's coming into her eye. So what we'd want to do with the camera is we'd want to place it exactly over that little white light. In the case of of you being under me in the microscope, it'll actually be a red flashing light. So the things you'd like to expect from this, well, noticeable improvement in your near vision can sometimes be seen the next day. We'd like to tell you the first week because there's a little bit of fluid that is inserted when I insert the device, and your cornea will take typically a week and sometimes a few weeks longer than that to sort of clear this fluid out of the central part of your cornea so that the little bit of haze you're seeing, a little bit of fogginess you're seeing will get clearer and clearer. But if we've got this thing where we want it, your near vision will seem improved right away. And there's often a bit of fluctuation. Again, this will come from dryness and just your eye accommodating to this device being in there. And we'll monitor this. We have a careful monitoring program. So typically see it back in a week, a month, 2 months, 3 months. By 6 months, nearly everyone has achieved an independence with this device. And during that 6-month period, though, we'll do whatever is necessary to get you the kind of vision we're looking for. So as an example, as I mentioned earlier, perhaps what we'll find is you're slightly in need of a bit more near power. And, of course, this can be achieved by putting you back under the excimer laser and providing that for you. And sometimes this isn't known until we actually get the device in your eye. So this could be a secondary procedure that you could require or not. So we sort of know that if we have you approximately in that zone of being a little bit nearsighted, that we get the best performance out of this device. What's cool is that once you do achieve success with this thing, once we've got you in that stable place, that effect should carry you out literally for the rest of your life. So I don't have any technology that I work with that has that kind of power. It's pretty cool for us to have the opportunity to work with this tool. So your vision will definitely fluctuate, as I mentioned here, and you may still need some magnification if you're in really dim light. As I mentioned, because of that small pupil aperture size, really dim light is the one slight weakness of this tool. So if you're in really dim light, that is the one circumstance where you'd want to shine some brighter light on it to give this device a little bit more power, or you throw in a pair of magnifiers. So the question is, how can I accelerate my recovery? And again, really, you just got to get your brain to train to using this new tool. It's using one eye to do your reading. You might be used to using both. So there's a little bit of a learning curve to find your way into that. There's lots of tricks we'll give you to get your brain and your eye working together so you can achieve that. Remember, though, what's so cool about this is unlike monovision, where one eye's out of focus for distance, one eye's in focus for distance, the distance eye therefore can't see close. Well, in this case, this eye can see both near and far. So therefore, when you see far, you'll have fusion. And fusion is a really important function that your brain has learned to do since you were a baby. So fusion is something we don't really want to break, but unfortunately we do when we try to achieve the same result with pure monovision. So this is a really, in a sense, a very cool way to do monovision. You have one eye that's doing your near vision, but it also is able to help out the distance eye as well. So use your eye drops. Yes, we have artificial tears, and sometimes we've got you on a medicated drop for up to a week or month, or even a couple of months. Again, getting yourself, practicing using the device is going to be part of the learning curve. For a lot of people, this is not exactly like a task they have to really work at. For some people, though, they've got a dominant eye, and that dominant eye kind of wants to be the boss. You need to kind of, coax it along. All right, so how do you move forward with this? Well, come on down. It's absolutely free, very cool, very extensive workup we'll give you. And by the end of that workup, we'll be able to tell you if we think you're a great candidate for this, and then how we would proceed in terms of getting you the best result with your camera. And if you like, book your camera procedure, and within a week or so, we think you're putting away those reading glasses, okay? So it's literally that straight up. Joyce here is my refractive coordinator, and you can call Joyce at any time. She can set you up for any convenient time for you to come down and see if you might be a candidate for this. It's fun just to even kind of have yourself evaluated by some of the really extensive equipment we have in our center. This is a research-based center that has some of the most advanced equipment that we have in our field today. So if you'd like to contact us, you can use that 877 number or just call Joyce at 630-724-1400. You can also find her online at the Glasses Free site where you can chat it up with her or even book an appointment.
You can email me directly to Joyce@glassesfree.com.
And Joyce's, there you are. You can get Joyce at glassesfree.com. So thank you so much, everybody, for coming on down. Obviously, when you would come in, you'll get my personal time to really explain your specific situation with your vision and your eyes, so I can help you walk through this process. And I'd like to get right up front and say that if I don't really think you're a great candidate for this kind of technology, I'm absolutely going to tell you so. I'm not here to push or in any way try and get you into doing something that wouldn't be the right thing for you. It's incredibly important for me that I feel like that you can be a success with this. And if this wouldn't be the perfect technology for me, then I would definitely tell you to not proceed with this. So I think we can open this up to questions.
Does anyone have any questions they'd like to ask Dr. Foulkes?
I got a million.
Go for it.
Go for it.
Okay. I'm 55 years old, and the question is, if I am a good candidate, which I'm going to come down and I need you to tell me if I am a good candidate for this solution. So the question is, if I'm 55 today, my eyesight changes very little, has changed very little over the last few years. Is there any way to determine how long into the future this will last?
Yes, great question, and I'm really happy you're asking that one, because you're right at that stage at 55, where you're as I was mentioning earlier, the lens in your eye stabilized about 5, 6, 7, 8 years ago because it could no longer flex inside your eye, or the lens became stiff enough that it really wasn't able to change. So you're absolutely correct.
The lens no longer, which is why when I go into the kitchen with bright sunlight and I flex my eyes, that's the reason I can get away from the glasses for a few seconds, because I'm getting that light in my eye, and the lens moves very little or slightly and allows that light in. Now the lens doesn't move at all and doesn't let the light in, so my near vision is gone.
Absolutely. So again, interestingly, you brought up another point, which is when you expose yourself to that bright light in the kitchen for a moment, you're actually shrinking your pupil size down to a small size close to what the aperture, right, the small hole in the camera is going to give you. So we're trying to give you that kind of vision you get for that brief moment when you walk into the kitchen. You can see everything, but on a permanent basis. Now, the question you asked, though, is how long is this going to last for me, really? And here's what's really, really, really interesting. I believe strongly now that with this technology in your eye, then remember, the next thing up the road for you is that cataract that just became stiff is going to become more and more opacified and start to reduce your color, brightness. Your night vision is going to get worse. And so at some point, we have a 10-minute procedure to replace that lens that you were born with a crystal clear little lens that we call an implant. So that little 10-minute procedure, of course, is paid for by insurance, and that's coming for you. So then the question would be, well, so will the camera still work for me? And in fact, not only does it work for you, but it actually seems to work even better once our cataract is removed. You can just imagine you've got a brighter, a lot more light rays essentially passing into the retina at this point, and so that the image quality will be even better once the implant's in your eye. Now, we have implants that can provide kind of, let's say, bifocal-like vision. They're expensive. They cost, a couple $1,000s a piece. You place 2 of these in your eye, you're typically, having to pay out side of your insurance, $4,500 or so. Here, without having to do that, the camera, in our opinion, can get you the standard implant, the one covered by your insurance, a very high-tech implant, just doesn't have that bifocality to it. So in a way, if you can get yourself successful with the camera, you have your lifetime solution to near and far vision. And this is really one of the things I'm the most intrigued and interested in, because I believe that we have a possibility here of giving people this sort of binocular vision that can see with both eyes far, but they can maintain really decent, good near vision with their one eye. And this should hold you right through the period where you're going to have cataracts. Now, I did mention in the talk earlier that we do approach these cataracts a lot younger in life. We don't typically let you go to to 70 or 80 anymore before we do these cataracts. We tend to do them younger. So, that might not be that far up the road for you. And by the way, when you come in for your evaluation, if I'm detecting that you have a significant amount of cataract, even at this age, I'm going to let you know that, right? That this might be the next thing up the road for you, not KAMRA, but actually cataracts.
Right. So if let's just say, for argument's sake, that I was a candidate for the cataract portion, could I get the insurance to pay for that and the camera, or am I stuck out of pocket for it?
Yeah, the insurance will not pay for KAMRA, but it will pay for cataract surgery.
That's what I figured. I was hoping that it could get included so that they could cover both.
Yes. No. But it is of interest that you would have to pay for the so-called premium implant that has the bifocality in it when you did get your cataract surgery date to get yourself the bifocal vision. And if you own the camera already, that device is likely to do even better than it was doing for you with your cataract in the eye. So in other words, you've already trained yourself to use this tool. And I believe you're going to be able to use this tool through to the rest of your life. Pretty cool. And it's an interesting thing because, I was in art school once, and I learned all about 35 millimeter cameras. A good bit of my art involved using cameras. And it's really fascinating to me that we've kind of used this really well-known visual concept or, optical concept. And we've got a device that seems to live very quietly and happily inside people's corneas. We have to get it there, and there's definitely, you're going to be my friend here for the first, 4 to 6 months through this procedure while your eyes accommodating to this and we're getting you figured out. But once it settles in and once you get it figured out, what you see, you're going to keep. And we have patients out over a decade now doing very well. So we know that the long term of this looks very, very promising.
Dr.
So,
Foulkes, do you see the questions on the bottom there? A couple people
yes.
asked. Okay.
Yeah,
great.
I'm just going for it here. So someone asked about the negative effects of wearing reading glasses, and there are none really. You can still wear reading glasses. In fact, they will work just as well. Even it's almost like you don't see the difference of having them on or not having them on until you close your camera eye. Then you would see that, okay, I can't see near with my distance eye. So there is if you still need reading glasses for certain activities, there's no problem with wearing the reading glasses on top of the camera. But there is clearly a kind of a learned sensitivity to the kind of vision the camera is giving you. So the exciting thing is, for me, is to get you to really use this thing. And I'll even have patients do a little exercise where they kind of start reading with their camera eye and then slowly open their dominant eye. We usually put this in your non-dominant eye, by the way. Most of us favor one eye over the other. It's typically our right, most of us being right-handed. But it could be your left. And so we like to put this in your non-dominant eye. We put this in the fellow eye. And the reason for that is that we've learned over time that when you do that, that the non-dominant eye kind of figures out, this is my job. My job is to read. And the brain can accommodate to this very well. So the paradigm of using this thing has always been to place it in the non-dominant eye. You don't need it in both eyes. It will do very well typically for most people just in the non-dominant eye. Let me ask a question. Dr. Foulkes, what about my night vision? Will it make it dim? I mean, I've got this thing in front of my vision. Will I not see as well at night? Well, the answer to that is actually no. It doesn't seem to in any way affect people's night vision. I would have to say somewhat surprised by this because when I saw this object sitting in front of people's pupil, I thought, well, it's going to be darker at night. They're not going to be able to see well. They're going to have problems seeing into the dark. And in fact, we just haven't shown this to be the case. Now, some of this is because we're only covering the one eye. But even looking through the camera eye, patients will describe very minimal differences in the brightness. Now, some of this is those 8,000 little holes that have been placed in the device. And if you hold it up to the light, it kind of disappears in the light. It has so many little tiny holes in it. So I believe that's part of the reason that you don't see this dimming effect with this sitting over your pupil. The other thing that came up to me now, a colleague of mine, Dr. Tomita, he is in Tokyo, a good friend of mine. He placed these in about 8 years ago is when he started placing these in Tokyo. And he's now done somewhere in the neighborhood of 7,000 or 8,000 of these. So he has the largest group of patients treated in the world. And Dr. Tomita has also placed these in 7 or 8 ophthalmologists here from the United States. And I find that interesting when ophthalmologists will sign up to do a procedure. Usually that means they're kind of jealous of their patients. And this is, in fact, exactly what we found with the camera. There's once you've seen how well your patients are doing with it, with the technology, we're more inclined to go, hey, I think I want that. And so Dr. Tomita has only removed a handful of these out of those 8,000 and 9,000 eyes he's treated. And the general reason for removal, when it has had to happen, has been 2 fundamental things. Very rarely, an eye just doesn't tolerate this being in the eye, and we can simply remove it. We watched this carefully. You would know it. I would know it. It's very easy to determine if that is the case, and it could be very quickly and easily removed. And it should be underscored here how this is an absolutely reversible technology. So whatever I've done to you here, completely reversed as soon as I remove it. So a lot of things we do to eyes, for instance, laser vision correction, tends to be a bit more of a permanent effect. I've changed the curvature of the cornea. I can't actually put that back. I can try to reverse it, but I can't exactly put it back. So with the camera, anything we've done to you here, completely reversible. But oddly enough, in the Japanese population, he's had about 25 or 30 patients out of it. Remember, 8,000 that became, let's say, fixated on the idea that people could see it in their eye. That people could walk up and would be noticing that they had something in their eye. And I will just say that I have had several conversations with many of my colleagues that have had these placed, only to have them tell me it was in their eye before I noticed it was in there. Now, once you do know someone has this in their eye, it is possible to see it. And if that was something that bothered you, then you should know that it is true, that it is possible, once I know it's in your eye, to sort of get off to the side and actually see that I can see this in your cornea. But for most people, they find it's kind of cool. They think it's kind of a conversation starter, and it certainly doesn't look weird. It just looks like your pupil. So that's the other thought about this, and I just wanted to kind of get that on the table, that there's no question that once you kind of know it's there, it's possible to see it. But if you stand back from the eye, it will absolutely just look like your pupil. So there'll be no real obvious reason for someone to notice it's in your eye. So again, I'm going to be absolutely available to any of you folks who want to come on down for your evaluation. You can ask me your specific questions while you're there, about your particular vision. I think that the nice thing to say about our practice is that we're as inclined to talk you out of doing something as to do it. I am incredibly fixated on that I've done something for you that's going to get you success and get you happy. I have no interest in doing something to you that's going to take you the other way. And I'll do everything possible I can to make sure that happens. I live here in Chicago. I've been practicing here since 1993. My practice is out in Lombard. We're not going anywhere. And so we're here to support you and get you through this thing. Should you go on to get cataract surgery, I'm one of the higher volume cataract surgeons in the city as well. And we can, if we find, in fact, that when you come for your evaluation, that perhaps cataract surgery might be your best option, then I would be available for you for that as well. So, if you have any further questions, go ahead and email me or hit me up. Or what I'd really recommend, and I promise you it'll be a really cool visit, is just come on down to the center. Let us have a good look at your eyes, and I can show you around, let you kick the tires of the kind of equipment and technology we have in our center. I think you'll find it'll be a really fascinating trip. And so thanks so much, everybody, for spending the time with me this afternoon. And I hope this was helpful.